Good afternoon. My talk is all about the clinical nutrition in intensive care.
And request our chairperson to kindly introduce our speaker.
Doc, and we are in a 404 bed, and this is a part of the Max Healthcare group of the hospitals, which is having a 20 big and the small hospitals. Recently taken your Sahara from the Lucknow and the Nagpur. So this is one of the hospitals, 404 bed hospitals, and the manpower which manages these 404 beds are 2,300 people, which is in a direct employment other than the indirect employment. This is the ICU where I'm working. So moving my part, it's now remember one thing in a critical care, there is one part is the most important, that to make a patient alright in an ICU, you have to have a three-component fulfilled. Number one is the treatment part, second part is your nutrition, third is your physiotherapy. They all constitute 33.3%. Missing any one of the out of the three, your patient is not going to do that. Maybe you made a fantastic of the diagnosis, maybe you have given a fantastic of the treatment, but if you're not looking at the nutrition part, this patient is not going to make it. So the same thing which I am trying to say here, look at this all. So what is the benefit of giving the nutrition? And this is the list. If you have complications, shorter length of stay, because in our hospital there is one department which keep on working under the supervision of the deputy medical superintendent regarding the bed management in ICU, 24/7. So there is a crunch of the bed, hence we focus too much on the LOS, average length of stay in the hospital, average length of stay in ICU, other than what you are giving the treatment to the patient. Now, before I start, let's have learn about the difference between the fasting or ICU stress and the starvation or meal fasting. So protein calorie is 3+ in ICU patients who are hypercatabolic state. Gluconeogenesis will be 3+, because it's a something when you are not eating, you are not giving the substrate, your body is trying to convert the other non-carbohydrate substrate into the glucose to keep your vital organs alive, your brain and those your heart. Ketosis 3+ in a starvation, so don't get confused when your patient is coming with this and you're checking on that, you say it's a DKA. It's not a DKA, it's a starvation, go to the history. Albumin, it's basically still in a starvation or during fasting, it will be greatly decreased in that. Weight loss, more than 75% of the mean mass. Lean mass means your muscle mass I'm talking. So sarcopenia will be very 3+ in a critical ill patients, while in your normal patients who are doing the fasting or starvation, they will have a more of your fat contents decreased. And your urea is more than 10 gram in an ICU stress and less than 5 in a starvation or fasting. So critical ill patient, this is a very usual kind of a picture you see in your ICU connected to so many of the tubes and devices on a ventilator, and they have the kind of a hyperinflammatory response, cytokine, interleukins are in their place, and they through the circulation they affect the entire body. And the poor outcome has been basically associated with if you are not giving a nutrition, if the patient is malnutrited, they are always associated with the intake, imbalance of the essential nutrients or impaired utilization. What does it mean? Undernutrition. Look at this patient. Malnutrition, obesity and overweight again is a malnutrition. And the third, nowadays what we are talking right from the day when Dr. Singh is saying lifestyle related diseases, your stroke, ACS, diabetes, all they are lifestyle related diseases. And name anything, it is all related. Moving forward quickly, and what is the metabolic change you will have the malnutrition that you are not providing, or you yourself, the people who are sitting in this hall, look at your diet chart, what you are eating. You are having a predominantly carbohydrate and the fat-rich diet. You are having deficient in the protein. Your body needs a protein every day, 1 gram per kilogram body weight, and if you are not taking that, it will be taken from your muscle. Your muscle mass will shrink, you will have a sarcopenia, which you always have, and what we say is that the fat is replacing your muscle. 2 theses are going on in our hospital in a gastroenterology, which are doing the same thing. Fat deposition in your muscle mass. So if you are not taking the proper diet and not doing your physical activity, you are going to have the same problem. Unstable joints, pain, and everything. So metabolic change is short term. Increase in the BMR with maintaining the water soluble substrate to brain reflecting gluconeogenic activity which predominates, and a long term, again, liver steatosis, insulin resistance, suppression of the gluconeogenesis, which was there to protect your vital organs at the time of the fasting when you are not giving the nutrition to your patient in a hypercatabolic state. At that time, this process got decreased, so you are not getting those substrates, the glucose which your brain needs, your heart needs to work with. Heart and brain is basically made in a way that even with the 50 millimeter of your systolic blood pressure, your brain remain active, because it transfers its substrate material from your oxidation to the non-anaerobic kind of depending on your more ketone bodies and other parts to take up the, at the time of the shock and when your patients are. So, decrease in the metabolic rate per cell and preservation of the more metabolically active organs at the expense of the muscle. Obviously, muscle don't need. In case of the shock, as you see that if you are not managing patient's breathing, what the body will do, it will try to mobilize the blood from the periphery toward the center. Still you are not doing anything, then it will start mobilizing your strength circulation towards your heart and the brain to keep you alive. Same principle is here. So, how malnutrition affect the critically ill patient? And here is the list. During the acute phase, hypercatabolism is the rule, leading to the energy deficit. You are not doing anything like that, you keep on focusing on the treatment part. Diagnosis, treatment, not no nutrition support. Patients gradually going to have a sarcopenia or the autophagy. Decrease in the muscle, because muscle is your store for the protein. You are taking or not taking. So your muscle mass is going to shrink. That's sarcopenia, autophagy, right? And critical illness induces the gut dysfunction and dysbiosis. So microbiota, which is nowadays is basically made responsible for your diabetes, hypertension, Alzheimer, dementia, whole lot of the other thing. 3000 साल से आयुर्वेद कह रहा था वो तो बेकार था. अब वो modern medicine people कहने लगे oh there is a microbiota, there is a gut, flora in your gut which decides about everything. वो भी तो ये कहते हैं कि पेट आपका सब कुछ सेंटर हर चीज पूरी दवा देगा. Same things are coming now. We are going to accept that. Sarcopenia. Now look at this. A patient came with a normal nutrition, got admitted to the ICU with the sepsis with multiple organ involvement. We are not giving that, and you will notice that predominantly in a pancreatitis patient who is going to stay a chronic critically ill patient. When I am saying the chronic critically ill patients means any patient staying in ICU 8 and more than 8 days with any illness, irrespective. They are labeled as a chronic critically ill patients. And these are the situation you find a witness in these subset of patients, onco patients. Different patient coming with a chronic illness, for example, a COPD patient coming with acute and chronic presentation, stuck on a ventilator. You are not meeting out the nutrition requirement, the same thing will happen as you are seeing on your skin. And it is basically directly proportional to the poor outcome and the mortality. Now the consequences, and here is the list, nothing you have already mentioned that it adds into your complications, septic complications, your length of stay, increased cost and the death. And there is one study just to prove that point. Cumulative energy deficit. What is that? If it is less than 10,000, more than 10,000, look at the p-value. Systemic inflammatory response syndrome and ICU loss, they have gone up. If I am saying the significant p-value, it has to be less than 0.05. So look at that. It's a significant two-part that is adding. Way back in 2001 I am talking about. This paper said that if you initiate your early nutrition well within 48 hours as per the new guidelines, then your patient outcome is good. When these patients are on the ventilator and their patients also. I am sorry that basically this presentation was being made on my laptop, that on a Mac. Now I am playing it on a Word, so that's why you are having this kind of disparity. I don't know where the words are going. Satish. Same thing. Now, in this particular 2015, what they found that if you are giving they calculated the calorie by 5 kilocalorie per kilogram body weight to the patient. And if you are seeing this, a Kaplan-Meier graph, and the red, they are getting only 50%, and the orange or middle one, 50 to 80%, and the more than 80%. They found the green one, which has more survivability and the less of your mortality. Now, same applies to the protein. If you are not giving the proper protein, and look at the green one, and the yellow one, I think that they change the side. If you are giving the total protein 0.8 gram per kilogram body weight right from the day one, then again it's having the low, survivability. You have to give the 0.8 gram per kilogram body weight for initial 1 to 3 days. I'm going to discuss in my subsequent slide. And thereafter, after 3 days, you are giving the full protein which you calculated for the patient. We'll just learn that. Goals of the nutrition. Here is the list. Provide the substrate to the metabolic function, positive nitrogen balance, prevent any deficiency, improve immune function, improve organ function, modify stress response, prevent metabolic complication. Very quickly, I'll take one point. Protein, there is a 3 basic components of the nutrition: carbohydrate, fat, and the protein. Out of the 3, it is the protein which is most important. Why? Because protein at the time of your body, if you are not taking carbohydrate, it can convert into the carbohydrate, it can convert into the fat also. But the carbohydrate, fat cannot convert into the protein. Protein is your body building material. All your cells which is getting damaged every day are being replaced by the newer cells, and the cell walls and everything needs a protein. By nature the protein. Your enzymes by nature protein. Your immunoglobulins by nature are protein. So you need a protein for your own survival, whether you take it or whether you don't take it. It totally depends on that. Look at this, the Ghana. Here. deficiencies. Now, some of the definitions you should know very quickly. What do you mean by the actual body weight? And here is the weight measured during hospitalization or reported just before the hospitalization. Ideal body weight is the weight related to the height, and the adjusted body weight is the applicable to the obese patient and calculated as a weight ideal. This is the formula. When you are giving the nutritional support to the patient, for the obese patient, this formula you need to apply. You can take that snapshot, all the students. Isocaloric diet means whatever calorie you have calculated and you are giving the same, that's the isocaloric diet. What is hypocaloric diet or underfeeding? It means whatever calorie you have calculated for that patient on that particular day, if you are giving less than 70%, 70 or less than 70, that's a hypocaloric or underfeeding, adversely going to impact the outcome. And what is the overfeeding? When you are giving 110 and more than that, that's overfeeding. Remember one thing, underfeeding and overfeeding both are detrimental and associated with the adverse outcome of the patient. So your patient has to give an isocaloric diet when you are keeping an eye on your management. So what is the trophic feed? It is being said that because you are having a gut microbiota, during your systemic inflammatory response, if you initiate your gut feeding quickly, so this particular bacteria do not transmigrate through the gut into the circulation, causing a further sepsis, endogenous bacterial infection. Other than that which you are having, and this helps in by preserving your endothelial epithelium, stimulate the secretion of blood-water enzymes, enhancing immune functions, preserving epithelial functions, and tight epithelial cell function, and preventing the bacterial translocation. So trophic feeding should be initiated at the earliest, whether you are giving it in a full dose or not, and supplemented with the supplemental parental nutrition or protoparental nutrition is the entirely different thing. So kindly give me a reminder 5 minutes before my time is over. What is the low protein diet? The protein you have calculated for a particular patient, if you are giving it less than 0.5 gram per kilogram body weight, and remember one thing, calculate your protein also from today itself, how much protein you are taking every day. How to initiate? Now quickly come to that. I've discussed everything in the introduction. How to proceed with that particular patient. You have to segregate the patient, that this patient is malnutrited, this is in the normal nutrition. And that you will do with the assessment and the screening. So assessment and the screening will be done with the, in MAX, we use the subjective global assessment tool. That's inbuilt because we are in a CPRS system, that's a computerized system, all 20 hospitals work on that. So on the click of the button you get all the information, there is no paperwork in that. Except in ICU, the nurses charts, except that everything will be done through the computer online. Everything. So SGA is the one tool which is used by NACS to assess the nutritional status of the patient, but remember one thing, SGA is basically meant predominantly for the IPD patient, not for the ICU patient. So there is a different scores as you are seeing on your list, MUST, NRS, and MNA or mini nutric score, but the red one which I mentioned the last is basically meant for critical ill patients. That's a nutritional risk score in critical ill patients. Again, there is an addition of modified nutric score where what they did was, these are the components of the nutric score which is applied to the critical ill patients. There is 6 parameter, age, Apache 2, SOFA, number of comorbidities, date of hospital, and IL-6. What they did was in a modified score because IL-6 is not available everywhere, while rest of the things you can do here at your periphery, in your nursing home everywhere, is the modified nutric score. And the score is anything 6 to 10 is considered to the mild, moderate to severe, while less than 5 is the low risk patient with the nutrition deficiency. So you have to segregate your patient by the time you receive. And remember one thing, we did right now a 400 patient database. In the last 3 months we did our own pilot to find out whether the SGA is detecting more nutrition deficient patient or to our surprise, 33% of the patients coming to my hospital are nutrition deficient at the time they come. Remember one thing also, the guideline given by the Americans, they say that you have to start your nutrition by 7 days. No, it's not. Their patients are well fed, their patients go to the hospital well within time, while in India the situation is that the patient by the time you receive maybe for 20 days, कितना खा रहे थे? सर खाना तो खा रहे थे, सर 2 टुकड़े ले रहे थे जी, बस थोड़ी सी खिचड़ी खा ली, दलिया खा लिया. That's not a nutrition. So remember one thing, the patient with the history for the 2 weeks back, patient was not taking the normal diet, patient is already nutritionally deficient by the time you see the patient in a hospital. Take that into the consideration when you are doing a screening. And these are anthropometric parameters which we use, although they are not used regularly in a critical ill patients, but in your hospital, you can take that snapshot. Weight and height gives you the overall nutrition. Triceps, skin fold, fat stores, arm muscle circumference protein, cellular, albumin and prealbumin gives you about the visceral, and then lymphocyte count, your immune status. So, moving forward, regarding history, very important, examination, laboratory findings. So what you will send in that to look into that part, and there is in the red you can see that albumin is having the high flag. Albumin is not a good marker for your nutritional status. It takes 3 weeks to change. So it's not a good marker. Transthyretin, all these investigations we are not doing routinely, truly speaking. I'm just sharing for the sake of the knowledge for the students who are sitting here, they want to know that. Transthyretin having a half-life of 8 to 10 days, pre-albumin 2 days, retinol binding proteins having 12 hours. They are not easily available everywhere. Calculation, how you will calculate? Protein haywire. I'll see. Carbohydrate and protein gives 4 kilocalorie per gram. Fat gives 9 kilocalorie per gram. This is how we calculate. Alcohol gives 7 kilocalorie, but don't take the alcohol that way because to fulfill your calorie requirement, please. So safe amount of the alcohol for the human consumption is 0. Any alcohol you are taking, 50 ml for large continuous recorded rate, go to your Robinson. You will find that you are going to have chronic liver changes in your heart. So the cholesterol change to the 4. So carbohydrate protein giving 4 kilocalorie per gram, fat is giving 9 kilocalorie per gram. This is how we calculate. All gone haywire. Can't do anything. Mac पे बनाया था और ये window पे चल रहा है presentation. No problem. I'll give you. So normal requirement of the protein is 11 gram. I'm talking the nitrogen. 11 gram nitrogen per day for the normal patient, for people who are sitting in this room. And the 1 gram of your, 6.5 grams to the 1 gram of the protein. Nitrogen I'm talking. Equivalent to the 25 gram of your muscle mass. Right? That's how we calculate. What should be the ratio of the protein to the calorie? Here, in a normal ratio, you have to give 150 kilocalorie per 1 gram of the protein. For 1 gram of nitrogen means 6.5 gram of the nitrogen. Just very quickly, I'm going to go through, sir. Thank you, sir, for giving the reminder. In critically patient, your 85 to 100 kilocalorie per 1 gram of your nitrogen equivalent to 6.5 gram of your protein. Right? Moving forward, how much calorie? Right. This is the formula which we apply, but it's a bit complicated. Gone haywire. Actual energy expenditure equivalent to the BMR multiplied your activity factor multiplied your injury factor multiplied your thermal factor. Sab gabad ho gaya. You can read it yourself. Quickly. Sepsis 25 to 30. My God. 20 minutes is over, sir. Just give me another 5 minutes time. No problem. So, what is the formula then? Remember one thing, for the simplicity of the calculation of the calorie, 25 to 30 kilocalorie per kilogram body weight is the universal given by the American Society of Enteral and Parenteral Nutrition, which is being utilized throughout the world. 25 to 30 kilocalorie. So, start with the 25 kilocalorie per, for a patient, calculate it, but don't give the complete calorie diet from the day one. You have to wait at least for you achieve 80% of your total target calorie well within 5 days. Giving early, then going to the refeeding syndrome. And this is the envy, you can take the snapshot. Energy 25 to 30 kilocalorie, glucose 3 to 4 gram per kilogram body weight per day. It should not go beyond that, otherwise it will lead into hypoglycemia further detrimental to the patient. Fat 1 to 2.5 gram per kilogram body weight per day, nitrogen 0.1 to 0.3 and amino acid 0.62 gram. This is a fixed, you should not cross that while you are replacing your nutrition per patient. Root, oral is superior to the enteral and to the parenteral depending on the situation of your patient. You can see that which way you want to see. Now this is the last slide, almost the second last slide. As I said, whatever calorie you calculated, whatever the protein you calculated for your patient. Now remember one thing, very practical formula I am giving to the audience. 1 to 3, 3 to 5, more than 5. So in 1 to 3 days you achieve your 50% of your total calorie to begin with and 50% of your protein intake in the first 3 days. After 3 to 5 days, try to touch your 70 to 80% of your calorie which you calculated for that subset of patients and the protein intake also. And for more than 5 days, you problem. This is how this basically a simplification of this particular slide. Now coming to my point, take home message. As I all know that nutrition is important, we have to look into it. Constitutes 33.3% of your total, recovery of the patient. Focus on that. Nothing new and discussing on that. So thank you very much for your kind listening. I'm open to the question.
Thanks, Doctor, for delivering such a wonderful talk. And our next, I request our chairperson to kindly facilitate our speaker.
Sir, please. digest or to metabolize that particular substrate, your body will use a more calorie for the oxidation. So your patient is critically ill, sick, already on oxygen, maybe on a ventilator, maybe having another organ involvement. So patient already in a deficit. Putting a more load on the already deficit body will create a more of a negative outcome. So hence, never give the more protein. As I mentioned, repeating again. First 1 to 3 days, 50% of your target of your protein and the calorie, whatever you calculated. In calculation, 25 to 30 kilocalorie. 30 kilocalorie will not be given on a day one. 30 kilocalorie will be given after 1 week. When the patient in ICU, chronic critical ill patient, 30 and above. Pancreatitis patient, 30 and above, after 1 week. So within 1 week, try to achieve your 80% of your target calorie and the protein intake of the patient, other than the essentials what you are adding on that. So that's the reason that your body consume more, calorie to oxidize the same substrate which you are giving to the patient. So that's the reason, keep it 50 to 80 and more than 80. 1 to 3, 3 to 5 and more than 5. Any questions?
So basically it's a very good talk. In fact, your coherence was so good, I was feeling that I am watching Kaun Banaya Crorepati. Your style is like that. Okay, so can you comment on the use of intravenous albumin in ICU?
Use of intravenous albumin in ICU. That's a very good question, and that is a very one topic which do have its kind of a discussion in all national critical care conference, right from almost more than 20, almost going to be 17 to 18 years. Use of IV albumin is needed only in two situations. 20% albumin to be given when you are doing a fluid resuscitation of the patient. A patient coming with the undifferentiated shock, suddenly collapsed. This is how I'll tell you that how the system works in our hospital where we are working. A patient comes from the two side to the ICU. Either they will come through the casualty trials, they can do the emergency. Through that they decided this patient go to the ICU, they will be sent to the ICU. The second subset of the patient coming from the ward. And from the ward, patient is coming in the two ways. Patient got deteriorated, RRT being announced. RRT is rapid response team, or cold blue being announced. Patient had a cardiac arrest. You went there, you resuscitate and retrieve the patient. So two ways the patient is coming to the ICU. When you are dealing with the undifferentiated shock in ICU, and you want to resuscitate, you want to know that which shock I am dealing with. For example, only 4 types of shocks we are dealing. Hypovolemic shock, hemorrhagic, non-hemorrhagic, obstructive shock, pulmonary embolism, or your maybe cardiac tamponade, cardiogenic shock, and distributive shock. Distributive shock means your sepsis or your neurogenic shock or anaphylactic. So they comes under the heading of there is only 4 types of the shock. Now you're in the middle of the night, you are deciding should I give a fluid or should I not give the fluid. Now the 20% albumin come to that part. For example, you found that my ejection fraction is very low, 20-25%. And why I'm saying ejection through? Because ultrasound machines are available in ICU. You have to do your own echocardiography. You know that differentiate between the shock, which shock I'm deciding. Because if you are giving a more crystal to the patient in this situation, when the patient is having a low ejection fraction, patient will go into the overload. And the first overload will be a VQ distress, will go into the lung. Because that's the least of your resistance. Rest of the other body will just compensate and just tolerate that. So 20% albumin will come into the rescue in that situation where you do not want to give too much of the fluid to the patient for the resuscitation, keeping a watch on your lung, on your IVC, on your echocardiography, which is now a part of the training of the critical care medicine, where ultrasound is being used for the management of these patients. We do it on regular basis. I think probably throughout the country people are doing that, and maybe in this part of the we are also going to use. So 20% albumin and 5% albumin being used in that situation. A sepsis patient coming to you with the distributed septic shock, with renal involvement, with lung involvement, and hemodynamic instability. 3 organ involvement. Patient is on the vasopressor. And now you did echocardiography, you found that the ejection fraction is 20-25%. Should I give a fluid or should I not give a fluid? My IVC is dilated. Ultrasound, lungs are B lines. In that situation, if I found that my patient needs a fluid, I switch from 20% either or 5%. You will not give the crystal because it will have a third spacing. So in that, other than that, albumin is not a replacement for your nutrition. That's not a part. So these are some of the limitations for the albumin, because every time you are giving, your capillary pore size is high during systemic inflammatory response. This protein will go into your third space, attract the fluid there, because fluid moves against your concentration gradient. Wherever you are having a high concentration gradient, fluid move from the one compartment to another compartment. So extracellular compartment, intracellular compartment, there is only 2 compartments. Fluid basically remain in a dynamic motion. So wherever you are having a concentration gradient high or oncotic pressure high, fluid will move from the low oncotic to the high oncotic pressure. So 20% or 5% fluid will be used only when you do not want to give a large volume, and they are not basically part of your nutrition. Nutrition is very clear. Either you give oral, you give enteral, or you give the parental, or you give the combination of the two, supplemental parental nutrition, which is running itself. Nutrition is a very big topic. I was given a task to finish within the 20 minutes. We take 8 lectures for our students to teach the nutrition in our department. Any questions, sir? Thank you, sir. Am I ready to give the answer, sir?
If a normal individual take high amount of protein, 2 grams per day, then what is, if a normal individual usually take high amount of protein in his diet,
so it will basically convert into the fat and deposit into your, wherever the fat will go, it will go into the liver. So remember one thing, today if you will have a chance, please get your ultrasound done and look into your liver. How much fatty liver changes are there. Remember, in India, the most common cause of your chronic liver disease, chronic liver failure, is your fatty liver disease. Non-alcoholic fatty liver disease converting into the NASH, and we receive minimum 4 or 5 patients in our ICU every month for the CLD, non-alcoholic fatty liver disease or the NASH. They are coming with the CLD presentation. So please look into your diet from today onward. Focus more on the protein, reduce your cut down on your carbohydrate, add your exercise on that.
Thank you.
Thank you, sir, for delivering such a wonderful talk, and we request our chairperson to do honor to our
Last question, last question.
During lunch.
Statement is that
During lunch.
okay.
During lunch.
discussion regarding during the lunch time, and request our speaker to do honor to our chairperson, Dr. P Singh Sahab, and Dr. SP Mishra Sahab and Dr.
Not more than 30 minutes. 20 minutes.